Hi, my name is Morgan Edens, and today we will be looking at the prevalence of post-traumatic stress disorder, otherwise known as PTSD, and some alternative therapy options. Mental health disorders or illnesses are characterized by a clinically significant disturbance in an individual's cognition, emotional regulation, or behavior. Mental health encompasses many different subcategories, such as anxiety disorders, depression, bipolar disorder, post-traumatic stress disorder, otherwise known as PTSD, schizophrenia, eating disorders, including bulimia, binge eating, and anorexia, dissocial disorders, and neurodevelopment disorders, commonly known as ADHD. Looking into the epidemiology of mental illnesses can be broken up into two categories. Any mental illness, which encompasses all recognized mental illnesses, and serious mental illness, which is when the causes significant functional impairment. In 2022, roughly 59.3 million adults over the age of 18 were diagnosed with AMI. It was more prevalent in females at 26.4% compared to the 19.7% in males. Adults aged 18 to 25 were at the highest risk of developing AMI compared to other age groups. White adults were the second highest reported behind individuals who reported at two or more races. Asian adults were among the lowest. Also in 2022, 15.4 million adults reported having an SMI. The prevalence was still higher in females, same as the age demographic. American Indian and Alaskan Natives were the second highest group, following behind individuals who reported two or more races as well. Post-traumatic stress disorder is characterized by the result of an extremely stressful and/or terrifying event, whether witnessing and/or being involved in said event. Symptoms in PTSD include intrusive memories, chronic nightmares, emotional or physical distress, avoidance, detachment, problem sleeping, and irritability. Causes of PTSD involve being directly involved and/or witnessing a traumatic event. Examples include war, house fire, criminal activity, and most common for women is being involved in sexual violence. Risk factors are broken down into three categories: pre-trauma, trauma, and post-trauma. During pre-trauma, you have a higher chance of having a traumatic event happen to you if you are female, have lower education, and you are more likely to develop PTSD if you have other mental illnesses. The severity of the traumatic event, along with the outcome of any physical injury, will impact the prevalence of development. Post-trauma risk factors include less social support, bigger financial burdens, length of recovery time, and likelihood of disability, whether through injury sustained and/or mental tensions. Diagnosis of PTSD is conducted with a pre-screening. This allows health professionals to evaluate prior to administering structured interviews. Examples of these interviews are clinician-administered PTSD scale and the structured clinical interview for DSM. Current offered treatments include antidepressants, most commonly known are SSRIs, benzodiazepines, and other prescription therapies to manage symptoms such as insomnia and nightmares. Epidemiology of PTSD. Roughly 70% of the global population has already experienced a traumatic event. Of that 70%, 5.6% will go on to develop PTSD. Outside of the 70%, 3.9% of the global population will develop PTSD at some point in their lives. Veterans are the most common group to have PTSD, as the likelihood of development increases 15.3% for those exposed to violent conflict or war. The median age for onset of PTSD is 23.7 years of age. Prevalence of PTSD. Women are 2 times as likely to experience PTSD. 7% of veterans were diagnosed following a traumatic event. PTSD is usually associated with individuals who have poor physical health increased morbidity, and those that seek healthcare more often for physical problems. A study done in 2016 showed PTSD was more prevalent in white or Native American individuals, younger populations, or those who have been previously married, ones that have a lower high school education, lower income, and those that reside in rural areas. Now to look into the financial aspects that comes along with the care for PTSD. In 2018, roughly $232.2 billion were used towards care. The annual cost of a military personnel with PTSD is $25,684, which includes health care and any disability payments after service is concluded. The annual cost of a civilian with PTSD is $18,640, which also includes related healthcare costs, but it doesn't also include the cost and coverage of unemployment. Even though the price per military personnel is higher, the military only accounts for 18% of the total financial burden, compared to civilians at 82%. The overall concept of PTSD is that stress from the traumatic event alters and causes permanent changes and damage to the brain. There are three main areas of the brain associated with stress: the amygdala, hippocampus, and prefrontal cortex. The increased stress causes changes to the neurochemical systems that are responsible for cortisol and norepinephrine level management. When stress is high, the hypothalamus releases corticotropin releasing factors, which interacts with adrenocorticotropic hormone. This interaction results in the release of cortisol. Thus, the more stress, the more cortisol is released. As the brain is very complex, please use this as a guide for functionality of different sections of the brain and the roles that they play in PTSD. Now we'll look further into natural supplements that individuals can take for PTSD, starting with ashwagandha. In a 2019 study that investigated over 8 weeks, researchers looked at stress levels and anxiety levels along with cortisol levels. The study included 60 participants age ranging from 18 to 55 years of age who had no history of previous psychiatric conditions. This was done in India. The intervention used KSM-66 ashwagandha root extract that was shipped in from California. This was done in 3 different groups. The first group was 125 milligrams of ashwagandha taken 2 times daily. The second was 300 milligrams of ashwagandha 2 times daily. And the third was the placebo group, which was 125 milligrams of starch 2 times daily. Measurement tools they used were the PSS, which is the perceived stress scale, serum cortisol levels. This was included at baseline, weeks 4 and at week 8. The Hamilton Anxiety Scale, HAMA assessment, the Standard Sleep Quality Questionnaire. Results showed lower stress scores in all 3 groups, with highest in ashwagandha groups, lower serum cortisol levels, lower anxiety levels in the 600 milligram group daily, as recorded by the HAM scale, and it also showed improved sleep quality. Limitations to this was that there was a very small sample size with only being 60 participants, and there was no indication for the need of therapy as there were no previous psychiatric conditions. In the study, there were no adverse effects reported by the participants. In this 2024 study, research did a study involving 121 participants ranging from 30 to 75 years old. All of the participants were non-smokers and they had a BMI ranging between 18 to 30 kilograms. The setting was a psychiatric outpatient clinic in India, and they also recruited participants from a social media advertisement in Australia. This included 59 participants in the study group, which was 300 milligrams of ashwagandha 2 times daily, and 55 participants in the placebo group. Measurements included a compass application for cognition, a POMS-A for mood, a brief A for executive function, and an MFS for fatigue measurements. The results showed reduced time for information processing in the study group. It also showed increase in accuracy of attention and increased working memory. Limitations for this study were that the placebo ingredients were unknown, there was low diversity in the population, and there was no history of psychiatric conditions. Just like the last study, there were no adverse reactions reported. Lastly, for ashwagandha, in this 2012 study, researchers took 64 participants between ages 18 to 54 with no prior psychiatric conditions. 64% were males and 36% were females. This was also done in India. This intervention had one capsule 2 times daily for 60 days. The study group was 300 milligrams of ashwagandha root extract, with the placebo group having a neutral substance. Measurements were cortisol levels, which was taken at baseline and at the end of 60 days, the PSS questionnaire, the Depression Anxiety Stress Scale, or the DASS, and a general health questionnaire, which was 28 questions. Results showed a 44% reduction in perceived stress in study groups, reduction in scores for anxiety, insomnia, and social dysfunction on the general health questionnaire, and then reduction in cortisol levels by 27.9% in the study group. Limitations was a short study duration, and once again, there was no history of psychological illness. The safety of this did report some small side effects, including mild congestion, constipation, cough, drowsiness, and appetite, and no appetite reported, but no major side effects were reported. Overall, the ashwagandha lowered cortisol levels and anxiety levels. It also improved sleep quality and increased attention awareness. Better results were shown when using 600 milligrams daily. The duration was not fully evaluated. Researchers looked at results over a period of 8 weeks, so to determine the half-life of the ashwagandha, further studies would need to be conducted. No adverse effects were reported at any dose. All clinical data supports the use of ashwagandha for alleviating symptoms associated with PTSD. The limitations included that all trials had no representation of previous diagnoses of psychological conditions, and all trials had smaller sample sizes as well as shorter time frames. Overall, ashwagandha can improve symptoms associated with PTSD. There are little to no side effects, which is a drastic difference when compared with standard psychopharmaceuticals. They usually require physician monitoring and weaning off if changing and or stopping said medications. Products found in retail stores have much higher dosing recommendations, so there is less clinical evidence to support benefits, and the side effects at these doses are unknown. When purchasing ashwagandha, individuals should look for the KSM66 ashwagandha root extract, as this is the industry standard. The second therapy we will be discussing is omega-3 fatty acids, which includes DHA and EPA components. In 2025, researchers took 83 participants who were in a severely accident injury, and they were survivors. The mean age of this group was 39. All of these participants were taken from the intensive care unit of the National Disaster Medical Center in Tokyo, Japan. The intervention included 300 milligrams of fatty acid 7 times daily for 12 weeks. The dose of the omega-3 was 1470 milligrams of DHA and 147 milligrams of EPA. The placebo was 987 milligrams of rapeseed oil, 525 milligrams of soybean oil, 525 of olive oil, and 63 milligrams of fish oil. Measurements included an electrocardiogram that measured heart rate, a Likert scale of self-reported measures, which took into account displeasure and anger and other emotions, and a clinician-administered PTSD scale. To go along with the measurements, researchers utilized script-driven imagery, which included 4 periods including rest, read, imagery, and recovery. Results showed reduced heart rate in the rest and imagery periods. Limitations for this study were there was small sample size, only 1 measurement period, meaning after the imagery was done, and symptoms of the PTSD were very minor in the beginning. Safety for this did show there was minor gastrointestinal upset, was reported along with fish burps. In a 2019 study, 18 participants with a current diagnosis of PTSD with veteran status were aged 18 to 65 were included in the study. This was done at the Durham VA Medical Center in Durham, North Carolina. The intervention included a control group and a placebo group. For one day, the control group was to take one capsule 3 times daily for one day, which was 325 milligrams of EPA and 225 milligrams of DHA. The next day was 2 capsules 3 times daily for one day, which was a total dose of 650 EPA, 450 DHA. And after that, from there until the end of the trial, it was 3 capsules 3 times daily, which was a total dose of 975 EPA and 675 DHA. Measurement included a clinician-administered PTSD scale, otherwise known as CAPS, the Brief Assessment of Cognition and Affective Disorders, BACA. Results showed both groups showed improvement in PTSD symptoms, with the placebo group having greater reduction in anxiety symptoms. Limitations were the very limited sample size, having only 18 participants, and this one only focused on individuals that had current PTSD diagnoses. The safety for this did show that 50% of participants reported dry mouth and restlessness, along with other minor symptoms. No major adverse effects were noted. Lastly, in a 2011 cohort trial, 68 participants, 38 of which were men, ranging in age from 21 to 29, all participants were taken from their second year of medical school in Ohio. Interventions included a study group, which was a total dose of 2,085 milligrams of EPA and 348 milligrams of DHA. The placebo group had palm, olive, soy, canola, and cocoa butter, which equaled the ratio of the US diet. Measurement included blood samples, which was taken at baseline and before major exams, the Center for Epidemiological Studies Depression Scale, the Pittsburgh Sleep Quality Index, and the Beck Anxiety Inventory. Results showed a reduction in anxiety symptoms, but not depressive symptoms. Limitations with a relatively healthy population. These participants were only aged 21 to 29. There was little variance in age, and minor stress levels were reported prior to entering the trial. The safety showed no serious side effects were reported, although minor side effects included sore throat, congestion, and GI upset. Overall, omega-3 fatty acids reduce symptoms associated with PTSD, including elevated heart rate during episodes and reducing anxiety symptoms. The dosing for omega-3 is 1 to 3 capsules daily, which typically includes 325 milligrams of EPA and 225 milligrams of DHA per capsule. Mild symptoms were reported, including dry mouth, fishy burps, and restlessness. No serious side effects were reported. The evidence was supported by various control trials that spanned over various lengths of time. The limitations included very small sample sizes. Although one study did include participants with current PTSD diagnosis, the symptoms were reported minor at the start of that trial. My recommendations for omega-3 supplements for PTSD are that they do not have clinically supported evidence for improving anxiety. Mild side effects were reported, but no major side effects that should deter individuals from receiving this. Throughout the trial, all dosing did vary. I would recommend to follow physician instructions or to follow the nutrition label on the back of the supplement. I would encourage research into the product to ensure it contains good amounts of both EPA and DHA. Other natural therapies that can help with symptoms of PTSD are ginger extract. Ginger is an antiemetic, anti-inflammatory, and antibacterial. Be advised when ingesting, as too much ginger can cause gastrointestinal upset. Chamomile also helps to reduce anxiety and promotes relaxation. And lastly is DHEA, which helps to naturally regulate cortisol levels. Always talk to your doctor before taking DHA, as it can affect natural hormone levels in both men and women. Some mind and body approaches that would be beneficial are acupuncture, which can open up the mind and increase cognitive function. Also is Tai Chi and Qigong, which helps to increase awareness and also awareness of breathing patterns. Lastly, here's a list of non-approved therapies, some of which are currently unavailable and some of which are also currently undergoing clinical trials like MDMA, otherwise known as ecstasy. Ayahuasca is illegal in the US, but is a psychedelic that allows neuroplasticity and reworking of the pathways in our brain. DMT is the active ingredient in ayahuasca, but can be taken separately. Psilocybin, also known as magic mushrooms, allows the person to have an out-of-body experience like ketamine-assisted therapy to allow us to look into our emotions and create new memories and connections. All of these alternative therapies is used. It should be used in conjunction with talk therapies. Here are my references. I appreciate your time and thank you for listening.